Is it audible?
Is it audible? Yeah, audible but echoing.
Now?
Now, now also
Still echoing?
anything?
What?
Now fine, I guess.
Okay.
Admit John. She's waiting in the lobby.
Good morning, everyone. We will be starting our second session on COVID-19 CME by 9:30 a.m. John, please on your camera. Good morning, sir. So shall we start, sir? Okay, sir. John, please start the session, second session.
Yes, Abu. Good morning to all who have joined in today to the CME on COVID-19. Myself, Joanne Joseph, Team at Lite welcomes you all present today to the day 2 of the CME on COVID-19. I hope all of you had a great experience on day 1, which was on 18th October last Sunday. The outbreak of novel coronavirus has created a global health crisis that has had a great impact on the way we perceive our world and our everyday lives. Not only the rate of contagion and patterns of transmission threatens our sense of agency, but the safety measures put in place to contain the spread of virus also require a certain extent of information, most importantly to those practicing and studying in the field of medicine, and hence Team MedLight hosts the first virtual conference on COVID-19, and we have come to the day 2 of it. Please note that e-certificates will be issued only on completion of the individual attendance on both the days of the CME, and I request all the attendees to extend their full participation till the end. On day 1, which was on October 18th, the discussion was on microbiological aspects on COVID, in which Dr. Abdul Nasir, MBBS MD, microbiology, with a fellowship in neuroinfection from NIMHANS, had a great discussion. Pulmonology in COVID, where the similarities and differences between coronavirus and influenza, pathogenesis, symptoms, stages of disease, etc., were discussed by Dr. Yunus Ahmed, MBBS DNB, specialist in pulmonary medicine. Preventive medicine in COVID by Dr. Farah Nas Fatima, MD DNB PGD HHM, Associate Professor, Department of Community Medicine at St. John's Medical College. Intensive care in COVID, which was discussed by Dr. Zahid Ahmed, MBBS DA DNB, EDIC Critical Care Program. Today being the day 2, we have a course of discussion on internal medicine, maternity in COVID, surgical protocols, and finally, case-based approach, which will be dealt by a panel of speakers, Dr. Thameem Saif, MBBS MD, who is a national level faculty, Dr. Anudeep, MS in General Surgery from Mysore Medical College, Dr. Shaistha Amreen, MBBS MS OBG from Shifa Hospital, and Dr. Haleema Yezdani, MBBS FICM diabetologist at Katula Healthcare. I welcome all the speakers to the event. Now, firstly, we have a discussion on internal medicine by a keynote speaker, Dr. Thameem Saif, MBBS MD, who is a national level faculty. I request all the attendees to attend his class, which will be a great opportunity to all of us. Thank you. Dr. Thameem Saif, MD, sir, please join us.
ನೀ ಮಾತಾಡೋದೀಗ ಅನ್ಮ್ಯೂಟ್ ಮಾಡಿದಲ್ಲ.
Sir, it's not audible, sir. Please unmute, sir.
Can you hear me now?
Yeah, yes, sir.
Okay. Okay, so good morning, everyone. And I thank the organizers for giving me this opportunity for presenting in this session. I was just telling you that I got this very interesting forward from a non-medical friend. And as you know, in this pandemic time, many of our non-medical friends also are keenly involved in health issues and the studies and all those things. So what he was trying to suggest was that the webinars are going on increasing, cases are going on increasing, the earnings are going on decreasing, but what seems to be stagnating is the doctor's knowledge. So I think obviously this is not true. We have learned a lot in the last 8 months about this virus. Although we do agree that some of the drugs that were approved initially, we are now having a doubt whether they are going to work or not. But yes, the point that I want to stress here is that this is a constant flux. We are learning about a new virus, which is constantly changing. New data is coming up. and we are trying to understand it more and more. And this is the reason why I'm trying to stress this idea that we are discussing this in the last week of October, and maybe a month from now things would have changed a lot. So what I'm suggesting now might not be relevant about a month from now. So you're all aware the word COVID stands for corona. So this is coronavirus. That's what COVID stands for. D is disease, and it was discovered in 2019. And the actual causative organism was found to be a coronavirus, which is now called the SARS-CoV-2. Now, obviously, we have coronaviruses. We've been dealing with them from a long time. We have the alpha coronaviruses, the beta, the gamma, and delta. And the novel coronavirus that we're now talking about is basically a beta coronavirus. Now, if you look at the phylogenetic tree, we have the alpha, beta, gamma, and delta. And actually, the four most common coronaviruses that are responsible for causing common cold are highlighted over here. Now, it is in this beta coronavirus family that we are seeing the more dangerous one that are causing lower respiratory tract involvement that are associated with pandemics. The first one I remember still in the year 2002 when we came across the SARS. It was the fear of a pandemic was palpable as I was working in a medicine OPD, and we used to wear masks those days, and more than that, I definitely remember the many presentations that I gave on this topic. So 2002, 2003, we saw this severe acute respiratory syndrome starting from China, from the Guangdong province, and it spread across the world, and it was traced back actually from a hotel in Hong Kong, from where international travelers spread it all across the world. And very soon we saw around 8,000 plus cases with 774 deaths in a short period of time. So that is the first time we were, at least that I was aware of a coronavirus that was causing this kind of a pandemic. Around 2012, we had another virus coming up, and this was the Middle East Respiratory Syndrome coronavirus. And this was called MERS because it was discovered in Middle East in Saudi Arabia. And in 2012, it was found out again, it was starting from the bat. Now, this bat is coming up everywhere in most of these coronaviruses. What's the role of the bat over here is that the bat, in order to cool itself, it puts a lot of its saliva on its wings and it flutters its wings. That's how it's air conditioning itself. That's how it cools itself. And this fluttering of the wings at high frequency allows the saliva to be dispersed like in the air, and that's how it is getting transmitted. So bat is becoming a very sophisticated way of how many of these respiratory viruses which are traveling through droplets, they are getting spread. In this case, the MERS coronavirus was found to be going from the bat to the camel, and from the camel it had mutated, and then it had come to the human. Now, this MERS cases are still ongoing here and there. We are still seeing cases reported. Unfortunate thing, obviously, is the case fatality rate is much higher than the current coronavirus that we are seeing. And most of the cases, however, were restricted to the Gulf. Around 2000, in the December-January month, we started hearing about a virus, a novel coronavirus, first reported in NEGM, and then it came obviously in many other places also. And around Jan, we had a good idea that this is a coronavirus. It is causing lower respiratory tract infection. It is causing pneumonia, and it brought back the memories of what we saw in the SARS coronavirus in 2002. And things spread very rapidly. Our grandparents had not seen it. Our parents had not seen it. We were witness to history in the making. And you could see that starting from December 2000, December 31, 2019, how rapidly the sequence of events occurred. Very soon it had spread across China in the Wuhan city, where, from a wet market where it started. And it was first case was declared, fatal case was declared in Jan 11. It had spread to Korea, Nepal, Japan within a few months. Although Wuhan was shut down by Jan 23rd itself, but by that time it had gone out because of the international travel. And the first case in India was reported on Jan 30. So if you look at the stage of any pandemic, obviously you know the starting point. And here also it was the Hunan wet market, which happened to be the initiator. And these dark boxes that you're seeing, this is in the market area, the people who got infected, and all these light boxes which you're seeing actually are outside the market, that is in the city as it was spreading. So again, it was the bat that was playing a central role in this, and from the bat, the virus had this is one of the theory that we have, that is gone to the pangolin, and from there it had got the necessary mutations to involve the human. So Again, just like how we saw in the SARS virus, here also we are seeing that it is spread, and this is a sequence I was telling you that December 20. Before that, we had no idea about this kind of virus. By Jan 10, it had been identified. Diagnostic tests were developed in Jan 12. So one of the advantages of having being exposed to the SARS virus earlier, we were much better aware, and the developments happened much more faster at this time around. And India, as I was telling you, the first case of coronavirus was found in Kerala in Jan 30. And by March 11th, WHO declared this as a pandemic. And now what we are seeing, the reality is that more than 39 million cases all over the world. And what's unfortunate is if you look, India is right on top, and it's second. And this is taking into consideration the fact that the number of cases reported in India are definitely going to be lesser because many states are not doing adequate testing. So in all probability, we might be having the highest number of cases, and if not, we'll be overtaking US very soon. So this is where we stand, and obviously we know that it is spreading through the close contacts, through airborne. You have micro droplets, you have larger droplets, you have fomites, and in all these ways, this is how it is spreading. If you look at the R naught, this is each person on an average how many people he is able to infect and spread. The x-axis over here is the spreadability, this is the R naught. And on the y-axis, what you're seeing is the mortality rate, the case fatality rate. So how dangerous or how virulent is the virus? Notice that definitely MERS virus is much more dangerous. Ebola is much more. Spanish flu was much more. The SARS-CoV-2 is much lesser in that sense. But then it's R naught is somewhere between 2 to 2.5 is what we are saying. Each person on an average is going to spread to around 2 to 2.5 people. Notice that this is way less than measles. Measles, the spreadability is very, very high. But unlike MERS, the spreadability is much more than MERS in SARS coronavirus 2. So what we are worried about is we've seen SARS coronavirus 1, we are going through the SARS coronavirus 2. Imagine if there is SARS coronavirus 3, which has the spreadability of measles and the virulence and the case fatality rate of Ebola. So that combination obviously is going to be pretty dangerous. Now we had got exposed to the SARS virus earlier, the MERS virus earlier. What was so different about the COVID-19 that it's spreading so much? Because SARS did not spread that much, neither MERS spread that much. But what made COVID-19 that problematic was this very important idea that the patients were in both SARS and MERS. The spreadability was occurring only in people who are symptomatic. So once people become symptomatic, then they take precautions, they don't go out, they are more restricted, and generally the spreadability starts decreasing. Unlike that, the peak spreadability of COVID-19 we are considering is on day 0, that is when the symptoms start, and actually 1 or 2 days before that. And this is the reason why it is very difficult to control this virus, because, for example, if I am talking to somebody now and I'm totally healthy right now, but I might be having the virus, I might be spreading it. Tomorrow, day after, I might feel a throat pain, then I start feeling the fever, and then the things start, but then I'm already spreading it. So the point that I'm trying to tell you is that one important graph, if you understand, then you'll know why wearing masks, wearing the distances, having the hand sanitizers, all those make sense, is because the spreadability that is this is from nature. As you know, the index value of nature is very, very high. And what they are trying to tell is the peak time when the virus is spreading is just before the symptoms start. So about 1 or 2 days before, even before the patients start developing fever or cough or any symptoms, the person is already spreading the virus. And this is the reason why this is becoming such a big problem, and it is spreading so rapidly. So obviously, the virus has been detected in so many secretions. The most important, obviously, the aerosolized, that is the droplets. But apart from that, it is found in the sputum, the saliva, the stools, blood, conjunctiva. Vertical transmission has been documented recently. It's supposed to be there in domestic animals like cats and dogs or dogs. However, there have been no reports of a virus spreading from the animals to humans, at least the domesticated pets. The significance of the other secretions and what role they have in causing spread of the virus is still not clarified. We also know that the virus is viable, but if you look at it compared to the amount of time it spends in the air, where it gets rapidly decayed every hour, the viability of the virus seems to be much more on plastic. and stainless steel. So this is just the half-life I'm showing you, just a comparison that compared to air, if you'll see copper is slightly more, then cardboard, stainless steel, and obviously plastic has got very high half-life where the virus might be viable for longer time. Although we are now understanding that many times, even though the virus is there, it may not be replicating rapidly and it may not be that viable for it to cause infection. So, however, precautions should be taken that whenever we're dealing with anything connected to cardboard, especially infected patients who are hospitalized or who are at home, then definitely precautions have to be taken to ensure that it's not spreading through some of these fomites. So although I'm sure it has been covered in the past, the pathophysio part of it, but I just want to highlight a few issues connected to the pathophysio and a few points connected to the virus before we start discussing about the medicine. Now, the word corona stands for the garland or wreath, and this is interesting because wreath is where you keep, what you keep for the funerals. So this is the word corona. I hope all of you are able to see my slides.
Yes, sir.
Okay. So the word corona, as I was telling you, means wreath, which they keep at the funerals, and that's an interesting term that they use for this. And anyway, corona also means a crown, and the spikes that are there on these viruses make it get that name. And as I was telling you about the various coronaviruses, some of them causing common cold, and the three ones that we saw that are creating the lower respiratory tract involvement. Anyway, as far as the coronavirus 2 is concerned, it is around 220 nanometers. It spreads by attaching to the ACE2 receptor. It has got the S and N proteins, and incubation period is roughly between 2 to 14 days, and generally 5 to 7 days is the median range for incubation period. So this is a virus that has got 13 genes, and it seems to make around more than 27 proteins. And interestingly, if you look at the virus, what you realize is that it's got 30,000 base pairs, which is a pretty large virus. Comparing with HIV, influenza, rhinoviruses, and other viruses, you notice this virus is longer. But then one of the things that we understand is that this is an RNA virus, and it needs the RNA-dependent RNA polymerase. And we know that the RNA-dependent RNA polymerase is not that accurate in copying the virus, and mutations are known to occur. And this is a common thing that happens in most of the other coronaviruses, that mutations are common and making most of the concept of a vaccine not viable. But what we are seeing in this current coronavirus too is that even though it's such a large virus, it's as I told you, it's 30,000 base pairs, but it doesn't seem to have so many mutations. And generally, the longer the virus, the more likely it should insert mutations. And generally, the advantage of having mutations is that enough mutations, if they occur, then the virus may spread, but it not be virulent, and it might burn out on its own. It starts having enough fatal mutations that it stops becoming viable. So that's the advantage of having more mutations. But the disadvantage is obviously with mutations, vaccine is out of question. Now, in the current SARS coronavirus 2, from the time it was found in Wuhan up till now, we noticed that the number of mutations are very, very minimal, giving rise to hope that the vaccine might work here. Now, the reason why this has been identified is that it has got a polymerase and exon enzyme, which is one of the things that corrects the errors. So any wrong nucleotide being inserted, these exon enzymes and polymerases are correcting. And this is the reason why you are seeing that the mutations are very few. And this is the reason why we are having high hopes. And as you already are aware, 23 vaccines are in a race. And we are already seeing many vaccines coming into the phase 2, phase 3 trials. And very soon we have our hopes high that the vaccine might be a realistic scenario. The development that we have now, the kind of technology that we have, we are able to identify the core pieces of the virus much better now. There's the cryo-EM. Now we are able to pick up the spike protein. And the spike protein is something that has been studied in a lot. We know that it is the area that attaches to the ACE2 receptor. And there's a zone this is the virus part. This is the place where it attaches to the ACE2 receptor. Now, interestingly, one mutation that is significant has been identified over here, known as the D614G mutation. And this initial virus that was identified in Wuhan and in China, to what we are seeing across the world now, in most places in the world now, the dominant virus that is there is this mutated virus. But then the thing is that this mutation that is there is not affecting the hopes of a vaccine, because this is just a minor mutation, and we're still very hopeful that most of the vaccines are going to be a success story. Now, you all know, I'm sure in the micro part, you would have come across this idea that the spike plays a very important role, attaches to the AC2 receptor. The temperase 2, which is a protease, helps in cutting the spike and allowing the unlocking mechanism. And the virus is able to put its nucleotide inside, the RNA inside, and that's how the replication starts. The more I read about the virus, the more amazed I feel of how evolved it is and how many it uses almost 1/3 of its genome in evasive techniques. It prevents being picked up by the cytoplasmic sensors, and it prevents being tagged as foreign, prevents being picked up by HLA class 1 and presented to T cells. So it's got a lot of evasive techniques that it uses, and that's one of the reasons why again it can successfully replicate and spread. Now you notice over here this actually electron microscopy, and you can see this kind of small vesicles. We are now understanding that the virus is able to create these small vesicles, pockets in which it can replicate without being picked up by the sensors and without being shown to the T cells for adaptive immunity. So when somebody asks me, is this a virus that people have created? This is definitely a big no, because the more you read about this virus, the more amazed you feel how evolved it is, how sophisticated a system it is, how it is trying to evade the immune mechanisms in many of the patients. So definitely, we know that in this virus, there's a significant role of understanding about the immunity. We have the innate immunity and we have the adaptive immunity. The innate immunity is the initial first line defense. And then the adaptive immunity kicks in, where the T cells play a very important role in boosting of the immune responses. We have the Th1 response, the Th2 responses. Those are all the adaptive immunity. What we understand about the SARS-CoV-2 is it causes a transient suppression of the adaptive immunity. The innate immunity is firing on all full cylinders. It's basically the innate cells produce a lot of chemicals that are known as cytokines. And these cytokines, broadly, you can classify. Some are protective in nature, but some of them cause inflammation. Unfortunately, in certain segment of patients in whom the disease becomes severe, only in a minority of those patients in whom the disease becomes severe, the protective cytokines are not coming out. There seems to be a delay in them at least. And the inflammatory cytokines are increasing and the adaptive immunity being suppressed. So the overall concept that I'm trying to tell you, rather than going into too much detail of this, is that the fact that the adaptive immunity is suppressed allows superadded secondary infections, bacterial infections, and other problems to occur. The fact that cytokines are coming up will cause a lot of inflammation, and ultimately we talk about something called a cytokine storm. So the immunity behind this is very interesting. Although if I had the time, I would have gone into detail and explained about the various immune mechanisms of how the COVID-19 is causing problems in mild, moderate, and severe. But just to give you an idea that, as I was telling you, that the virus does have a lot of evasive mechanisms. Let's say it infected this cell, and using its evasive techniques, it does not allow any clue to be given to the surrounding cells that this cell is infected. Normally, one cell is infected, it releases type 1 interferons that warn the other cells to up their defenses so that the other cells are not infected. So this is all part of the innate immunity. Now, in the SARS-CoV-2, what it's doing is this primary cell which has got infected, it's not able to alert the other cells, but the body is able to find a way, and this is mainly through the plasma dendritic cells. These plasmacytoid dendritic cells are able to pick up the broken piece of the virus. They alert all the other cells that the patient has got a viral infection going around, and the defense is up, and the disease is mild. In a majority of patients, as you know, that hospitalized patients in coronavirus is supposed to be only 5%. In that, the mortality rate is supposed to be anywhere between 0.5 to 2%, depending on which age group and which area you're looking at. So in majority, that means almost 90% of people, that they are going to do well in the SARS-CoV-2, and the disease is going to be mild in a significant number of patients. And the reason why it is mild is thanks to the innate responses, and the type 1 interferons are supposed to play a very crucial role in majority of people having a mild infection. But we know in some people, the type 1 interferon production is a problem. And in patients who have moderate disease and severe disease, we know that the virus is not controlled by the initial innate responses. It is able to spread. It is able to be picked up by the dendritic cells, presented to the lymph node, the T cells in the lymph node, germinal centers form, and antibodies are being developed over there. So basically, the adaptive immunity is kicking in a significant number of people, and they still recover. And this is moderate kind of COVID that you see. They have some cough, they have some pulmonary involvement, but they start recovering. Unfortunately, there are a small segment of patients, and I told you this category of patients. Only 5% get hospitalized. In that also, the very severe patients we see around 2%. So this very severe infection, definitely the initial protective innate responses are not working. The virus is able to spread. As it spreads, it releases lot of cytokines, not the protective cytokines, but the ones that cause inflammation. And also it is a suppression of the adaptive immunity. And this is one of the reasons why we are seeing a lot of inflammation occurring in this condition. This is what we refer to as the cytokine storm. So what antiviral immune responses that should have been helping us in defending against the virus, they become the enemy, they become the problem. And this is the issue that we are seeing in these patients. So actually more than the virus causing the damage is the host inflammatory immune response that is creating a problem. And that is what we refer to as a cytokine storm. For a long time, it was not clear why in some people this problem is occurring and why in majority of people they are coming up with a mild infection or moderate infection and they're recovering. Some light in this is breaking out now, and there's a new dawn coming up. Science has published two important studies. One is about the type 1 interferon linked, and many people who are elderly, who are diabetic, they are now identifying that there is a problem in the type 1 interferon production. Also, in a significant number of patients, antibodies against type 1 interferon have been found. So what plays a very critical role, type 1 interferon, in the very initial infection, the protection is not there in some people, and they are open, they are exposed. When the virus enters them, then they are going to cause problem. They are going to have issue because the initial innate response are not working. The protective innate responses, they are not working. The inflammatory cytokines produced by the innate system is going to create havoc, and the virus is able to replicate very rapidly in those patients. So at least now we're having an idea that in a minority of people, there is a germline loss of function in the type 1 interferon. And that was seen in 4% of patients and about 13.7% of patients in people who develop severe. Remember this idea that only severe, not mild people have this issue, that they have antibodies against interferon. So you and me, some of us might already be having antibodies against type 1 interferon. And those of us who have this, we are not able to hold the virus in the initial phase. The virus is able to replicate more rapidly, and it's going to cause more problems. So at least we have an idea now. At least in 20% of patients, we are able to explain what is the reason why they're developing very severe. Out of the 5% hospitalized I'm talking about, at least we have an answer now. What is the reason why in some people the virus is spreading like anything and the defense system is becoming weak. So I think in the coming months, we'll have more clarity about why some people are selectively picked up. And what we say is the biggest risk factor in COVID is the age. The older the person, the higher the risk of hospitalization and mortality. So age is the single most important factor over here. But apart from that, diabetes, pre-existing cardiac diseases, and so many other things are also there that increase the risk. But now we are understanding that the occurrence of these antibodies against type 1 interferon and the problems of type 1 interferon mutation, the loss of function, might be a very important way in predicting about who is going to develop a severe disease. But as I was telling you, in the coming months, we are hoping to crack this even more and understand exactly why some people are selectively affected more. Some of them younger people getting severe disease. What is the reason for that? And I think that clarity is going to increase in the coming months. One thing's for sure, in the autopsy studies, we saw that there is an inflammation driven by the innate immunity. That means it is neutrophil driven, it is driven by macrophages. So it is basically innate cells. And in fact, the lymphoid system is getting suppressed. And you're actually seeing a lymphopenia in these patients. So you do see that the endothelium is the primary area affected, particularly the pericyte on the endothelium has got the AC2 receptor. It is the main cell that is getting affected. And once the pericyte gets affected, as you know, the endothelium is going to be significantly hampered. So endothelial inflammation is definitely critical. And what it ends up is causing a problem in the barrier between the alveolar and the capillary zone. And that is going to result in the interstitial pneumonitis. That seems to be the big problem in these patients. So in patients, definitely what you see is the alveolar wall, and you can see this is how thin and nice it should be. But in patients, see how thick the interstitium is going to become, and this edema and the inflammation that is there in the interstitium. Naturally, then the hypoxia is expected because the oxygen transfer across this membrane is going to be significantly compromised. Apart from the inflammation and the interstitial pneumonitis that is obvious in this condition, and the main place which is affected obviously is the lung, because that's the route of entry of the virus. So the lung is significantly affected. it is going to cause the alveolar inflammation, which is interstitial pneumonitis. But one interesting thing that we saw in the autopsy studies was a lot of thromboembolic phenomena is found in this condition. Now, how the SARS-CoV-2 is causing this thromboembolic state has become more clear now. We know that the endothelial damage causes the release of tissue factor. This tissue factor is one of the things that activates the coagulation mechanisms. Platelets start sticking to this. And once platelet plug starts occurring, causing thrombocytopenia, you'll also see clotting factors are getting activated. Another problem is the complement is activated by SARS coronavirus because it blocks the regulatory zone called factor H, which regulates the complement. This factor H being blocked by the virus, uncontrolled complement activation also damages the endothelium and also causes activation of coagulation. Then we also know now that there is something called neutrophil traps that are there. This neutrophil extracellular traps, they actually are very critical in controlling bacterial infection in other places. But right in this particular scenario in this virus, these traps that are there formed by the neutrophils actually become a viscous zone where there's slowing of blood, and that also adds to the reason why coagulation occurs. So the clarity of why coagulation is occurring in this condition is becoming more obvious now. And as I was telling you that SARS coronavirus blocks the factor H, and by blocking factor H, which is an important regulator of complement, we are now seeing that complement is activated, and that activated complement allows for more endothelial damage. And that's how the endothelial damage causes platelets to attach, and the coagulation cascade is activated. The clotting system and the coagulation cascade is activated. To summarize then, if you remember the Vishwas triad, we have a vascular endothelialitis. We have various activations, that is including the viral RNA, the neutrophil traps, the von Willebrand factor, thrombin, fibrin, mesh, all these things are activated. And then also you have slowing of blood. So all these three put together, the stasis, the inflammation, and the hypercoagulable state put together results in the patient developing a lot of thrombogenicity. So now it is understood that one of the reasons why you don't see typical ARDS picture in these patients is because of this thromboembolic phenomena. We're also understanding that in most patients in whom desaturation occurs, anybody with interstitial pneumonitis desaturation should have been at a lot of distress, but we now coin a term called happy hypoxia, where people have got a lot of desaturation, but they come to your hospital walking, they have mild distress. And one of the reasons for this is because typically ARDS, for example, comes at a shunt phenomena. You don't get that shunt over here because the vessels also are getting blocked. And the reason why the vessels are getting blocked is because of the thromboembolic phenomena. So this is what you see in a normal person. Okay, I don't know whether you're able to see this. This is in a normal person what you're able to see, but in the COVID-19 patient, see how the pulmonary vessels are significantly affected. So this is nothing but the thromboembolic state that is blocking up the many vessels in the lung, creating a problem. So to summarize then, way back in the early months of April, May itself, we had figured out that the virus is going to cause problem in three ways. One, it can be mild, it can be moderate, it can be severe in some patients. So in the mild, we do see the viral replication. Now you should understand that even in mild people, they are able to transmit the virus because the viral load is equally high. So it's not that only severe people have got high viral load in their throat. Even the mild people can have a high viral load, but their innate immunity is working very nicely. The defenses are working properly, and they are able to overcome the virus very easily without going into a cytokine storm. And that's what you see in majority of patients who have mild symptoms. In some patients, you do see dry cough occurring, fever, conjunctivitis, and X-ray will show the opacity, the ground glass appearance. Now, in these patients, what we see is that it seems to be a biphasic pattern where the virus is there initially, and then slowly after that, the immune system is creating some minor issue, and this is the biphasic. However, what is problematic is the very severe state where the patient has more symptoms. The virus is able to spread not only in the lung, but involve other organs also. And the viral load is higher in these patients, at least in the later stages. And the immune system is creating the big issue. And this is what we talk about the cytokine storm. So in general, now we understand the concept of what is happening in this condition. There is an incubation period initially, I told you, after exposure to the virus, and that roughly is around 5 days in the median period. Now, after that, the patient start developing symptoms. Don't forget, I told you already that before day 0, when the symptoms start, the patient is already in a mode in which he's able to spread the virus very efficiently. So initially, we talk about the viral dominance, where the patients got the viremia, the viral responses are, I mean, the virus is replicating very rapidly. It's creating the problem. Whether viremia is there or not there, it depends obviously whether it is a mild case or a severe case. So in most of the patients, if you trace this, they start recovering and the patient is out of the problem by about 10 days. Generally, you will see that the most of the patients have come out of the disease. But in some patients you see severe disease and then you see critical disease. In some patients you do see the biphasic pattern where they become severe but they still do recover. But it's the very critical patients who are going to develop a very strong cytokine storm that we see that they go into hospital, getting into the ICU, get intubated, they end up with severe lung damage, and those are the patients that are associated with higher mortality, the critical zone. Now, this chart is very important. This is one chart. If you understand, then we'll know that what we are doing, what we were doing wrong in our treatment, and what we can do correctly in our treatment. In general, you can break up the entire process over here into a viral dominance phase and a host immune response phase. And this is the crux of understanding about the treatment, because we have drugs that can hit the virus and we have antiviral drugs and we have drugs that hit the immune system. Now, when the virus is dominating, at that time giving anti-immune drugs might be counterproductive because they allow the virus to replicate more, and it in fact can be counterproductive. This is what we saw in the studies also. Like if you see dexamethasone, which is against the immune responses, if used initially, like say day one itself, patient got fever, started taking dexa, then overall the person actually worsens more, because in the initial phase when the virus is dominating, what we need is antiviral measures to work, and the immune system at that time actually is helpful. But when the immune system is going high, all guns, that is, you're talking about the host immune response dominating, at that time the antiviral drugs may not have much benefit, because in a significant number of patients the virus starts coming down. And for example, I'll just give you an example. We saw so many studies on convalescent plasma. Now, what is convalescent plasma? People who have recovered from COVID, they have antibodies in the blood, their plasma is utilized, and that is being used to treat these patients. Now, the timing is critical. At the time when the virus is dominating, definitely antiviral measures like convalescent plasma, remdesivir, whatever drugs we have against the virus, they work when the virus is there. When patient already has got antibodies against the virus and the immune system is dominating, at that time trying to treat the virus by giving convalescent plasma or remdesivir or any of these things are not going to work. The point I'm trying to tell you is, you have an initial viremia phase, you have an initial viral phase, and then you have a later host immune response, host immune phase. In the initial viral phase, the antiviral drug should be used. In the later, when host immune response is dominating, drugs that are hitting the immune system like tocilizumab, steroids, those are becoming important. If you do not have proper timing, then obviously the treatment is going to be a failure. No wonder then many of the convalescent plasma studies that have been done, obviously is getting rectified now because we understand the pathophysiology better. But many of the drugs like remdesivir or convalescent plasma were not giving at the proper timing when the virus was dominating, and they were not being used at that time. Rather, they were being used already, the virus load was coming down, the host immune response were hyper. At that time, antiviral measures may not have much benefit. So I think that's one of the reasons why we are seeing the studies are fluctuating so much. But now that we have a clarity of the pathophysio, the studies that are happening in the last few months are becoming much better. So where does the virus spread? Obviously, the most important area is the upper respiratory tract and the lower respiratory tract, where the ACE2 receptors, that's the route of entry. But the ACE2 receptors are identified in the heart. So we do see heart involvement, we do see the GI involvement, ileum and esophagus particularly, and the stomach. The bladder is getting involved, so cystitis is described. The liver is involved, so you do see serum transaminases increasing. So a variety of organs in the body are involved in the virus because the ACE2 receptors are present not just in the lung, but in many places outside the lung. If you look at the typical clinical manifestations, one of the studies was showing that you have fever as the most common presenting feature. But one of the NEGM articles that came out looking at 1,000 patients in the month of March itself, and it showed that fever is not an absolute feature. Almost 30 to 40% of patients in their series did not have fever at all. So there's no sacrosanct feature over here that it has to be there to make the diagnosis, but we look at a combination of features. So you have fever, you have cough, fatigue, anorexia, shortness of breath, myalgia, but then some special features that are kind of unique to this virus, and that is the loss of smell, the taste alteration. Those things are also going to give us a clue. Left eye conjunctivitis has been identified to be a peculiar thing seen commonly in patients with COVID. So the severe COVID patients are going to develop the bigger problems, and this is the pneumonitis I was telling you going into ARDS. You have a hyperinflammation occurring, resulting in fever and other manifestation inflammation. Acute cardiac injury is becoming a huge issue. Kidney injury, neurological problems, hypercoagulopathy, as I told you, and then in children we are talking about a multi-inflammatory syndrome, which I'll talk about later. One of the peculiar things we're seeing is something called COVID toes, and it's now becoming clear that this COVID toes is because of the microangiopathy that is occurring because of the thromboembolic phenomena, and that is one of the explanations given as to why this kind of toes are seen in these patients. So moving to diagnosis, the diagnosis of SARS-CoV-2 depends on three main aspects. One is the RT-PCR, which is picking up the genetic material of the virus, amplifying it and picking it up. Then you have the antigen tests, which are the more rapidly, rapid tests, or what we call rapid antigen tests. They are cheaper, but they don't have the sensitivity of the RT-PCR. And then you have the antibody tests. Obviously, you understand the antibody tests are not going to have a role in the diagnosis of acute COVID-19 because the antibodies take time to become positive, and they usually start becoming significant about 2 weeks to 3 weeks after the patient start developing the infection. And obviously, antibody has a very important role in finding out the number of people who are already got infected. Now, as I was telling you, RT-PCR is the most important thing, and if the virus is plenty, then the machine does not need to amplify many cycles to pick up the virus. So a low CT value actually indicates that the machine did not have to amplify a lot. Already virus was plenty and the diagnosis was done. So a low CT means the viral load is more. The more amplifications are needed to pick up the material, genetic material. That means the number of viral copies in the nasopharynx must have not been much. So the higher the CT value obviously means that the viral load was not that high. Now, as you can see, the way the RT-PCR is being done, how deep they need to go, the sensitivity is varying. Part of the reason why the sensitivity is varying anywhere between 60 to 90% is because if you don't go deep inside and take the sample from the right place, then you might actually not get the test positive. This explains why some patients are going to one place, getting a test done, and then going to another place, getting a test done. Once it's coming positive, another is coming negative. The reason for that is part of it is sampling errors, part of it is how much the copies we were able to get. So a lot of things are involved in why the sensitivity is varying, but then it can vary anywhere between 60 to 90%, as I was telling you. No doubt RT-PCR is very specific. Now there is something called pooled RT-PCR. There's all household contacts. If you want to look at bulk level, if you want to, and this is cost cutting measure obviously, but it's one of the things that is approved. And what we do is many of the contacts that the patient had, take everybody's sample, feed it in the machine at the same time, and if the test comes negative, then more or less you can say that most of the people who are in contact were not infected. If the test comes positive, then you have to individually test each person because one of them has to have the infection. Then we have the rapid antigen test I was telling you. It is definitely cheaper, it is faster, it's as specific or highly specific as RT-PCR, but the sensitivity is lesser. But you need to understand that a lesser sensitive test doesn't mean anything bad. It might be beneficial. Those states which are doing rapid antigen tests, you will find that their controlling measures are even better. So you can see a very nice picture, the graph that you can see here. So obviously you would want to pick up the virus at the lowest level. Even 10 viral copies you want to pick up. That's highly sensitive test. But a less sensitive test like rapid antigen test can pick up, let's say, at 1,000 viral copies. The thing about the virus that we have is that the SARS-CoV-2 doesn't take much time to go from 10 copies to 1,000 copies to 100,000 copies. It's a matter of few hours before it is going to multiply. So the gap that you get, which is marked by this red zone, is very narrow. Unless you are hitting it in that very red zone, you don't have to worry. Even if you have a less sensitive test, you're going to be fairly good, because when the virus becomes infective, at the point when it is spreadable and you have 100,000 copies and all that, then the rapid antigen test also picks it up, RT-PCR also picks it up. Now you might argue, what if the patient is the viral load starts coming down, and a majority of mild patients, we know the viremia the viral load starts coming down, and after some time you notice this yellow zone where the rapid antigen test can't pick it up, but the RT-PCR would have picked it up. Now again, because the viral copies are so less, you know that it is not going to be spreadable. So because it is not going to spread because of the viral load being so low, then we don't have to worry. The point that you need to understand is the difference between the rapid antigen test and the RT-PCR is given by the red zone and the yellow zone. The yellow zone doesn't matter to us because anyway the virus is not going to spread, because the number of copies are so low it's not spreadable. Then what matters is actually the red zone, and that is too small a thing. So actually you'll notice then the rapid antigen test might be highly beneficial, even though it's less sensitive. That less sensitivity might actually be a benefit in doing it, because getting a test rapidly, cheaper test, is definitely going to be more productive and more useful.